Hi, my name's Holly. I am a clinical coach here in the PICU, so you'll see me around. I'm going to walk you guys through a general assessment of a PICU patient. As you guys know, our PICU patients have a wide range of ages and conditions, so every assessment is going to look very different. It's going to be tailored to that patient. However, there is a general structure that's important to get down and remember so that we don't miss anything or leave anything out. Also, our PICU patients are sicker than most patients. They have lines and tubes, airways, a lot of things, so it's easy to get caught up in one thing and leave other things out. So that's why I'm going to walk through a head-to-toe assessment, and I'm going to incorporate checking on those tubes and also doing different cares head to toe so that we don't miss anything. As ICU nurses, we're constantly assessing our patients, but every 4 hours we have a dedicated time to do an assessment, and this is when we look at every inch of our patient, assess everything again so we don't miss anything. Okay, so the first thing that we're going to do when we walk in the room is our safety checks. This is before you ever touch the patient or look at the patient. So the first thing we're going to check is our code sheet. Every patient should have a code sheet at bedside, and it's usually in this little clear thing. So the things we're going to check are their age and their weight. And as long as that's correct, then the code sheet is right. So those are the important things to check. So then we'll do that, and then we will come all the way around the bed to check their bag. Every patient in the PICU should have a bag and a mask. So we're going to pick, the bag will always be hanging here, or it should always be hanging here. So you're going to pick your bag off. Make sure that you have a mask that's an appropriate size for your patient. And then you're going to make sure that your bag inflates. And then put it back. And then you make sure that you have suction set up as well and that it's on. So you can come over here, make sure that's turned to continuous suction. And each patient should also have a yonker at bedside. But just to make a note of it, if they're trached, we're going to make sure they have the same size trach and a size down at bedside, and if they're intubated, we'll make sure that they have spare tape. Okay, so part of our safety check is our monitor, our Drager. So the thing that we're going to do before we assess our patient is come over to our Drager and make sure that our alarms are on and that they're appropriate. So we're going to scroll to our heart rate first and click on that, and that's going to bring us down here to heart rate alarm. It's going to bring the main table. So our heart rate, we can see our upper limits here and our lower limits here. Also, what we notice first thing is that our blood pressure alarms are off. So we have all these alarms that are on and these are off. So we're going to make sure we turn those on, which I will learn more about. And then we're going to make sure that now that our alarms are on, we're going to make sure that the limits, the upper limit and the lower limits, are appropriate for that patient. So we have a 6-year-old patient, and our heart rate alarm, the upper limit is 120 and our lower limit is 20. So is that an appropriate lower limit for our patient? That means that the 6-year-old patient could be sitting with a heart rate of 20 and it would not alarm, it would not notify us. It would only notify us if it was 19. So we have to think about if that's appropriate limit for this 6-year-old, and PALS tells us that it is not. So we're gonna go to this limit and we're gonna raise that to, I say, 60. So we're gonna save that, and then that will alarm when it drops to 59. And then the other heart rate alarm that we need to mention is the Brady alarm. So once we change that heart rate alarm, we're going to go to Brady alarm. And so this is telling it's going to have a louder alarm, a Brady alarm, whenever it's less than 40. And so we usually like to raise this 10 point, or lower this 10 points below our lower limit. So we're going to put this at 50. Okay, and so we turned our blood pressure alarms on, so you'll make sure those are appropriate as well, just like we did the heart rate. And then the respiratory rate, we're gonna check the apnea time, and it's set at 20 seconds. Okay, so before we start our head-to-toe assessment, we've already done our safety checks. The next really important step before we really get into our assessment is the general appearance of our patient. So for pediatric patients, if you have a baby or a small child, when we start assessing them, we're going to agitate them, and their vital signs and their appearance is no longer going to be what they are at baseline. So that's why the general assessment is really important. And so when we first walk in the room, the first things we're going to assess are their general appearance, their color. Are they pink? Are they pale? What do they look like? We're also going to check their neurostatus. So are they awake? Are they talking? Are they crying? Do they not care that you're in the room? Those kinds of things. And then respiratory status. Are they working hard to breathe? Very generally, what do they look like? And then another important thing is to step back and take a vital signs snapshot. So look at their heart rate, look what their oxygen saturation is, blood pressure, respiratory rate. Look at what that is before you start messing with them, because you're going to get halfway in your assessment, realize that they're tachycardic, hypertensive, and not know if that's from you agitating them or that's what their current status is. Okay, so now that we've done our safety check and our general appearance assessment, now we're going to move into our head-to-toe assessment. And just a reminder, we're going to include any kind of interventions like checking tube placements and cares like oral care and things like that. We're going to integrate all those things to just do a very generalized head-to-toe assessment. So we're going to start out with the head. And so this is an older patient, but for our infants, we're going to check fontanelles first. So we're going to check the interior and posterior fontanelles. We're going to feel them to see if they're soft and flat or bulging, full, what do they feel like. And then after fontanelles, just for any other aged patient, we're going to check the appearance of their head. Do they have any abrasions, bruises, swelling? Are they microcephalic? Is there any asymmetry going on? Generalized head assessment. Then after we assess that, we're going to go to their eyes. So don't have my pen light, but we're going to check their eyes to see if they have any periorbital edema, scleral edema, redness, the color of their sclera, is there any yellow tint to their sclera, and then we're going to check their pupils. So we're going to use a light and check if their pupils are brisk and reactive to light or they're sluggish. We're going to check the shape of their pupils. Is it round, oval? Are the pupils different sizes? That kind of thing. And then while we're here at their eyes, we can also do eye care. So for our patients that can open their eyes on their own, I typically just use gauze and saline, clean out any crusties. But if they are intubated patients or they're not able to open their eyes on their own, we would use lacquer lube, a lubricant, to keep their eyes moist. So then while we're here, when we do the pupil check, this is a good time to do our neuro exam. So we'll give them a GCS score. Do they open their eyes spontaneously? Are they talking, etc.? Do they move their arms or extremities spontaneously? Do they withdraw to pain or touch? All that stuff. And then once we finish with our pupil exam and our neuro exam, we're going to go to their nose. So here we see our patient has a lot going on in their nose. So they have the cannula and their feeding tubes. So for their cannula, we're going to follow it back and see what it's connected to over here. So we're going to check their FiO2. So he's at 100% FiO2. And then we're going to check their flow as well. So his is at 7, okay, let's see, yeah. So 7, So this is really important to check. This is not just your RT's job, but your job as well to see what they're on. So he's on high flow. And then after you check that, we're going to look at their tubes. So right here you see we have a feeding tube. And then we're going to check where it's placed at. So this is at, let's see, 25, 24. It's at about 22 and a half. Should probably not be accurate on a real patient, but we're going to check and see where it's at. And then to check placement, well, we can see that's connected to feeds. So we're checking their feeds, we'll check their rate, all that good stuff. And then for placement, so I'm going to pause my feeds and take out my feeding tube, or the feeds. And so this, or feeding tube, we're typically going to feed our patients, especially if they already have an NG tube, which is gastric, then this is most likely transpyloric. And so how we assess that, I'm going to take a syringe, this is our oral syringe, I'm going to hook that up and pull back on it. So typically what we're going to feel if it's transpyloric is we're going to feel a snap. And so when I pull back on this, you can see how the plunger just kind of falls back. So that tells me that the tube is up against something, which is what we want to see. We don't want to just be able to pull back easily, and if we are, it might be gastric. So we're going to pull back, see if we have any residuals, and if we do, measure those, because we're going to chart that, note that, and then we can also listen. And so if our tube is transpyloric like we think, then we should be able to hear it down lower, and usually on the right side. So we're going to inject some air and see what we hear. And then, once we check that placement, hook that back up and restart our feeds and go on to our NG tube. So this tube should be gastric, and it looks like it's connected to suction. So we're going to check and see what our NG is connected to. If it's to suction, we're going to make sure that it's on. Sometimes they're to gravity. Just assess that. And then for placement of NG, it's similar. We're going to hook up our syringe, pull back and see what our contents are, if they're gastric contents, what they look like, what color. And then same thing, we're going to inject some air and listen right at the belly and see what we hear. And then for our nose, we've checked all of our tubes that are in our nose. We're also going to suction and see if we have any drainage. So suction out their nose and note if their drainage is thick or thin and what color it is. Okay, so now that we're done with the mouth or the nose, we'll go to the mouth. So just generally we'll look around, see if we see any sores. Make sure that the mucous membranes, his tongue is pink and moist. It's not dry, or note if it's dry. Look and see if he has teeth, if he has any trauma or injury. And then we make sure the palate's intact, that kind of thing. And then sometimes they'll have tubes here. You might have instead of an NG, you might have an OG. Same thing, checking the tube and checking placement. And then this is where we'll do oral care, which, just to show you, this is what our oral care looks like. And so we'll do that there when we assess his mouth. And then we can assess the secretions as well, just like we did with his nose when we do oral care. That's it for the mouth. Then we'll go on down his neck. Some of our patients have trachs, so this is where we'll assess his trach, look at the size, look at his ties, make sure that we can get 1 to 2 fingers in between the ties and his neck, make sure that it's secure. Then okay, so now that we're done with their head and our neck, we're going to move on to their abdomen. So the first thing I'm going to do is auscultate. And keep in mind, if you have an infant, that you should definitely auscultate first before you agitate them, otherwise you might not be able to hear anything. But now we're going to listen to breath sounds first. So doing that, listening for if they sound clear, coarse, diminished, if they sound equal on both sides, diminished in the bases, don't hear sounds on one side, all that kind of thing. Then you can look for chest rise. Is it even bilaterally? And then we'll go down to their abdomen. So auscultate in all 4 quadrants, and you're listening for bowel sounds. Are they present, absent, hypoactive, hyperactive? And then you can also inspect their abdomen. Is it rounded? Is it flat? Is it distended? Is it soft? Or is it taut? Then after we inspect that, we'll go into their extremities. We will assess pulses. So for our babies, we're definitely going to check their brachial pulse. So we're going to check a brachial, radial. We'll do that on both extremities. We're going to look at cap refill and look at it on their nail beds or on the palm of their hand. Check for how many seconds. And then we're also assessing, like we've done before, color and temperature. Does it feel cool or warm? And again, abrasions, redness, rash, anything like that. So for cap refill too, we checked it on their extremity or on her hands, and also centrally we'll check it. You can check here or on their forehead to check the central cap refill. And we'll compare that to their extremities. And then go down to the legs and take off their socks. And we'll check pulses. You can check a pedal pulse. You can check post-tib, popliteal, or femoral in the babies, and compare those pulses. Then again, cap refill. And on the babies, it's a lot easier to check it on their heel. And then, so we'll change the pulse ox location as well. So if it's on their feet like this, then I just switch it. I'll probably leave the cuff here. We want the cuff in a different spot than our pulse ox, because every time the blood pressure takes, it's going to cut off circulation and our pulse ox isn't going to read. But we can change the blood pressure cuff to a different extremity, because we want to do that every 4 hours if we can, if we have a spot to change it to. And so now we're going to check our lines. So we'll check the site, we'll check the skin around it, the color, decide if there's any bleeding or redness. Also every 4 hours we'll check patency, we'll flush the line and check for blood return. This line doesn't have anything running in it. And then we'll check our pick. Do the same thing, check for blood return, check patency, and then this one does have something running. So always trace our lines back and see what's running and make sure we check that. Then we also have a PIV, same thing, checking the site, color, and then we'll flush it, make sure it's patent, make sure it's not swollen or puffy or hard, definitely. And then check and see what's running, follow our line back. And then this one is not a male or a female, but we'll check the peri area. And if they have a Foley, this is where we'll do Foley care. Make sure that it's not leaking or anything. And then after we do all of that, we'll make sure and roll our patient and look at their back. This one has a pad. We'll look at their back, same thing. We're looking for any redness, rash, anything abnormal, pressure sores,